So this topic we will discuss under the following headings like introduction. Actually, you have given the introduction, congenital heart lesions in detail about the pathophysiology. We will discuss only the commonest lesions which we come across in our day-to-day practice, and risk stratification of these lesions when they come for the non-cardiac surgery. And in section 2, which is clinically important, that is regarding about our anesthesia management. So introduction, as sir has said, that the incidence is 6 to 8 per 1000 live births. Babies are having congenital heart diseases, and because of the development of the procedures, treatment modalities, these babies are coming more and more for the non-cardiac surgeries. But still, these patients are at high risk because the studies have shown that the mortality among the pediatric patients perioperatively is 6.1% compared to the mortality with the pediatric patients without congenital heart disease, which is 3.8%, which is the doubled, and that's why we should be worried for these patients. Out of that, 54% cardiac arrest occur in the general OT, and this is more worrisome when we are doing anesthesia for the non-cardiac surgery compared with the safe environment of cardiac OT and cath lab, which is 26 and 17%. Another entity about the congenital heart disease lesions, the patients who come to us in practice are either they are having the disease which is not corrected, or they are palliated, or they are fully corrected. So the mortality is more in uncorrected diseases, like 59% compared with the palliated patients, that is 26%. 70% of the cardiac arrest occur under the age of 2 years. So in short, when a patient having congenital heart disease less than 2 years and uncorrected have a high mortality, and we should be cautious. The scenario of India and congenital heart disease: every year 2 lakh babies take birth with congenital heart disease. In comparison to Western countries, the treatment modalities in India are not up to the mark. So, small about the basics. We all know that after birth, there is transition of the circulation of fetal circulation, which is parallel circulation. It get transformed into the series circulation of adult life. But in congenital heart diseases, this doesn't happen, and that's why we have to face the sequelae of these parallel circulation after birth. Pediatric cardiovascular system, so far we all know that the pediatric cardiac vascular system is immature. The immature LV and RV, as compared to the adult LV, they are immature, and RV is more predominant initially, and later on the LV becomes dominant and the structural changes occurs. Sympathetic nervous system is poorly developed in pediatric patient, and so far the catecholamine stores are also depleted in them. We always seen the parasympathetic nervous system predominance in the congenital in the pediatric patients. Myocardial contractile function needs more calcium and glucose, and they are weak compared to the adults. And the LV compliance is also less compared to the adults, and so they don't respond to the preload, rather than they are depend on the heart rate and sinus rhythm. So it is very important to maintain the high heart rate, or heart rate proportional to the age of the patients. Coming to the today's topic, congenital heart disease classification has been done, mainly the cyanotic heart diseases and cyanotic heart diseases. Cyanotic can again classified into the conditions which have an increased pulmonary blood flow. We also call them as left to right shunt lesions, and these are the commonest to present atrial septal defect, ventricular septal defect, patent ductus arteriosus, and AV canal defects. Obstructive diseases, these are coarctation of aorta, aortic stenosis, and pulmonary stenosis. Their incidence is less than the left to right shunt diseases. Cyanotic heart diseases, they are classified depending on the either decreased pulmonary blood flow, or there is mixing of the blood flow. The conditions, we all know the most common prototype is Tetralogy of Fallot. Then comes the tricuspid atresia, Pepstein's anomaly, and mixed blood flow conditions are TGA, TAPVC, truncus, and hypoplastic left heart syndrome. We will just see the basic some congenital heart diseases in detail because of constraint of the time. So atrial septal defects, which is the most common congenital heart disease we come across, there is a intercommunication between the two atria because of the defect in the interatrial septum. Depending on the position of the defect, they are classified as ostium secundum, primum, and sinus venosus. As there is a defect in between the interatrial septum, blood flows from the left atrium to the right atrium. Right atrium and right ventricular, these are the more distensible systems or chambers, so they accommodate the large flow easily, and these large flow goes to the pulmonary circulation through the pulmonary artery. And so in this condition there is increased pulmonary blood flow, and consequently there is RA-RV dilatation and pulmonary artery dilatation. If it is a small ASD, patient may not have any symptoms throughout the life, but it is a moderate to large ASD in late childhood or till the adulthood, they don't have symptoms, but then they start shortness of breath, fatigue, palpitations with exercise. These symptoms are because the increased pulmonary blood flow and the dilatation of the chambers and changes into the conducting systems as well. This is a chest X-ray. In congenital heart diseases, if we see the X-rays, we will never find normal X-ray as we find in others. They have changes according to their pathophysiology and chamber enlargements. So this is diagrammatic presentation of the pathophysiology of ASD. You can appreciate the chambers RA-RV and this pulmonary artery is enlarged, and large pulmonary blood flow comes to the pulmonary veins and LALV. So management, it depend on the symptoms. Coming to the ventricular septal defect, this is the second commonest condition which we come across. It is a congenital opening in the interventricular septum which connects both ventricles of the heart. Again, it has three types depending on the position of the defect in the interventricular septum: perimembranous VSD, which is the commonest condition, inlet and muscular VSD. This is a very nice diagram. There is defect in the interventricular septum and blood mixes from LV directly to the RV and then pulmonary circulation. The difference between ASD and VSD is that ASD, the mixing is at lower pressures, but in VSD, the high pressure chambers are involved. So whatever the blood from the high pressure LV goes to the RV and through RV into the lungs. Both are in the systole, so the direct gush of the blood goes to the pulmonary artery, and pulmonary artery has to face the systemic pressure. So while they are taking the extra blood through the VSD, and so there are pathophysiologic changes in the pulmonary circulation. Initially, adaptive mechanisms works, and there is dilatation of the pulmonary artery, arterioles, and subsequent changes in the pulmonary vascular bed, which we call in late stages as pulmonary vascular occlusive disease. And in last stage is Eisenmengerization, when they are irreversible. So initial period, when we treat these VSDs, whatever the pulmonary artery hypertension changes has been occurred, they get reversed, and that's why VSDs have to more address surgically or either device closure in initial days. So this is the diagrammatic presentation of the LALV, and this is pulmonary artery. And again, it takes more blood from the pulmonary circulation. So treatment again depend on the size of the VSD. Small, moderate, and large VSDs. They are graded according to the sizes, like up to the 7 mm can be called as the small VSD, 7 to 15 mm moderate, and more than 15 mm VSDs are large VSDs, or they can also classified according to size of the aortic annulus. But we should be very precautious when a patient comes in our OT with moderate to large VSDs, because they have already started the pulmonary artery hypertension changes, and they have more reactive pulmonary artery hypertension. So X-ray, you will see there is increased pulmonary blood flow and increased plethora, and the chambers are dilated. Third commonest condition is patent ductus arteriosus. We have seen the ASD and VSD, which are the communication at the chamber level. Now, patent ductus arteriosus, it has a communication at the great vessels level. There is direct communication from the aorta to the pulmonary artery, and so with same like VSD, high pressure blood flow comes to the pulmonary artery, and the changes in the pulmonary circulation occurs. They are same like VSD. So pathophysiology of the VSD and PDA is somewhat same, and the changes in pulmonary artery hypertension are also same. So we have to address these conditions as early as possible if the patient is symptomatic. This is the same X-ray of PDA. See the chamber enlargement and increased plethora. AV canal defects, the incidence of AV canal defects is 1 to 2%. These patients generally don't come in the general OT because these patients have to give treatment surgically for their disease within the 4 months of age. And so we don't come across the patients of these diseases for elective surgeries. Obstructive lesions again, aortic stenosis, pulmonary stenosis, and coarctation aorta. Out of that, aortic and pulmonary stenosis incidence is 1 to 2%, while coarctation of aorta, the incidence is little higher, but still they present if the coarctation is not very high till the late childhood and till adult age also. Now coming to the second classification of the congenital heart disease, and that is cyanotic heart disease. These babies we also called as blue baby syndrome. Cyanotic heart disease is also classified into two types depending on the increased pulmonary blood flow or mixing of the circulation and decreased pulmonary blood flow. The conditions are TGA, truncal, single ventricle, and TAPVC for the increased pulmonary blood flow. Actually, these conditions are having mixing of the saturated and desaturated blood, and so cyanosis appears. These the incidence of these conditions is also less, 1 to 2%, and these conditions have to address immediately within the first month either or within the 6 months of the birth. Decreased pulmonary blood flow conditions, tetralogy of Fallot, which we all very well know. This is a prototype of cyanotic heart disease. We will see it in detail. Other conditions are tricuspid atresia, abstinence anomaly, and pulmonary atresia. They have an incidence of 1%, and generally these patients we don't come across the in general OT. So little about the tetralogy of Fallot, prototype of all cyanotic heart disease. It has four defects, or we can say tetra, that is four components. First is a large malaligned ventricular septal defect. RVOT is right ventricular outflow tract obstruction. So from right ventricle, the outflow is through the pulmonary artery. So there is obstruction in the pulmonary blood flow either at the subvalvular level, valvular level, or infundibular level. There is hypertrophy of the right ventricle because the adaptive mechanism to this obstruction and overriding of the aorta. These four components are present in the tetralogy of Fallot. The severity of these obstruction determines the direction and magnitude of the shunt through the malaligned VSD. This condition is right to left shunt, can be called as right to left shunt. So the blood from the right ventricle directly mixes into the left ventricle rather than going to the pulmonary circulation and getting deoxygenated. But yes, for compatibility of life, there is some arrangement. The initially the this pulmonary obstruction may not be very severe, or there may be some kind of blood flow development of the collaterals, and somehow patient gets some oxygenated blood coming to the left ventricle and going to the systemic circulation. When this obstruction is not severe, there is some amount of blood going to the pulmonary circulation, getting oxygenated, and in this condition we call them as pink top or a cyanotic top. So in the initial period, they may not show cyanosis or the consequences of cyanosis. But when the stenosis is severe, we will see the cyanosis immediately after the birth. So bluish discoloration, parents they give history that baby after feeding, after crying or after defecation becomes more blue, and patient may have tachypnea, difficulty in respiration because of the hypoxia. So the important of the tetralogy of Fallot is cyanotic spells. Then there is a severe obstruction, and any stress or any sympathetic stimulation, pain, tachycardia, anxiety, it stimulates tachycardia, sympathetic stimulation, and so there is increased oxygen demand. But as the oxygen levels are fixed or less, they have hypoxia. Hypoxia leads to acidosis. Then child tries to compensate it with hyperapnea. So again, the consequences of this hyperapnea is decrease in thoracic pressure, decrease. There is a decrease in the SVR. So there is reduction in the pulmonary blood flow, and again increase in the right to left shunting. Patient again have more hypoxia. This vicious cycle goes on, and baby becomes very cyanotic and anoxic, limpless, or sometimes maybe unconscious or have convulsions like that. So we have to stop these cyanotic spells. But we have a lot of measures to treat these cyanotic spells, but body has also adaptive mechanism. These babies at home, when they have cyanotic spells, they on their own do the squatting positions, and by squatting position there is increase in SVR. As SVR increases, the shunting of the blood from right side to left side decreases, and so the patient gets relieved. So you should ask mother about the episodes of squatting. It will tell us about the severity of the obstruction. So treatment, as I told, niches position or squatting position, we can give 100% oxygen, but as there is a structural problem in oxygenation, it will have a less role, but still some 5 to 10% saturation can be increased after giving the humidified oxygen. We have to uh, keep the baby calm. That is, we have to ameliorate the sympathetic stimulation, pain, cry, whatever. We can give morphine injection if available, or we can give ketamine. Ketamine is the best drug to calm the baby, because ketamine increases the SVR, which is very very important to reduce the shunting of blood from right side to left side. Another important drug for the treatment of cyanotic spell is phenylephrine. The dose is 1 milliequivalent per kg. It also helps to increase the SVR and reduce the shunting of blood. These patients are dehydrated, so we can give fluid challenge, that is NS or RL 20 ml per kg boluses at times. We can properly hydrate these patients, because dehydration is also one of the cause of cyanotic spell. Beta blockers are very useful. As I have told, there is a RVOT obstruction, and RVOT obstruction can be relieved by the action of these beta blockers. The drug of choice is propranolol. If not available, we can use ismolol as well. So because of the cyanosis, continuous cyanosis since birth, they have some sequelae. To overcome the cyanosis, there is erythrocytosis, increase in the RBCs to deliver more and more oxygen at the tissue level. So there is secondary polycythemia. There are coagulation problems, low levels of all factor 5, platelets, high INR. Then iron deficiency anemia is also present in these cyanotic patients. Neuronal complications, they occur because of this polycythemia, thick blood. There is infarct, small infarcts in the cerebral circulation. These infarcts, initially they are sterile abscesses, but consequently they become the infected, and patient may have neuronal complications as well. So this was about the tetralogy of Fallot. Other cyanotic lesions are also present, which are right to left shunts are tricuspid atresia, pulmonary atresia, abstinence anomaly. But as I said, the incidence is just 1 to 2%. We will not go in detail. Mixing of circulation, yes. Transposition of great arteries, TAPVC, and single ventricular physiology. Uh, just short about this TGA, the aorta arises from the RV, and the pulmonary artery arises from the LV. So carrying the oxygenated blood again to the lung, and RV carrying desaturated blood to the body, and there is complete desaturation. See, this is a pictorial diagram about the transposition of great arteries. So to sustain life, there should be communication in between these two circulation. Either they have ASD, VSD, or PDA. Transposition of great artery patients, we have to treat complete correction or some palliation within the 4 weeks of life, otherwise they will succumb to death, and these patients generally don't come for the non-cardiac surgeries. Single ventricle physiology, it is a single ventricle physiology. Structurally there are two ventricles, but one ventricle is very rudimentary, so both the chambers, RA and LA, they open into a main chamber or a single ventricle, and so they have all consequences. We have to treat these patients immediately, less than 6 months of age. Abstinence anomaly, there is downward displacement of the tricuspid leaflet into the RV cavity. There is interatrial communication with right to left shunt is present. The hemodynamics are, because of the RV is rudimentary or less compliant, there is reduction in the forward flow through the right side of the heart. So coming to the risk stratification about the congenital heart diseases, before going to the actual anesthesia management, the incidence of extracardiac anomalies, other genetic diseases is 25% with the congenital heart disease, and so we should have a detailed history and detailed examination of these patients having any other associated anomalies. All records of treatment, we should go the frequency of hospitalization, recurrence of the respiratory tract infections, and episodes of congestive heart failure in case of large VSD. They will all tell us about the severity of the disease. Category, we come across three types of patient, as I told earlier. Either they are not at all corrected for their pathology, uncorrected patients, palliated patients, and corrected patients. Corrected patients generally don't give trouble because their pathophysiology has been turned towards the normality after the correction, but uncorrected and palliated patient, they carry the challenges to manage the anesthesia. The American College of Surgeons and the National Surgical Quality Improvement Program have divided these diseases into minor, major, and severe. ASD, VSDs, small to moderate VSDs, they come under a minor category of congenital heart diseases. But the major congenital heart diseases are the uh, Tetralogy of Fallot with pre-pulmonary regurgitation or left hypoplastic syndrome. These are little bit complex and they come under major category, and severe are uncorrected cyanotic heart disease coming for the non-cardiac surgery. Patients of VSD with documented severe pulmonary artery hypertension, patients with documented ventricular dysfunctions requiring medications, and the patient of congenital cardiomyopathies which are listed for heart transplantation comes under the severe category. This is a very beautiful diagram given by the American College of Cardiology and American Heart Association. So, how to proceed for non-cardiac surgery in pediatric patients having congenital heart disease? They have given clear-cut idea. Emergency surgery, we don't have time and we have to proceed for the surgery as it is emergency. But still, you have to include the team approach, like you have to include the pediatric cardiologist, opinion of pediatric surgeon. Pediatric cardiac anesthesiologist is very necessary to manage these cases because they are well versed with the pathophysiology, and they are used to the techniques of putting the invasive lines and manage the things. So if you have available pediatric cardiac anesthesiologist, you have to include them at every stage to manage these patients. They have stratified these lesions into minor, major, and severe. And for major, they have given risk stratification in the number of scoring, like depending on their status. So low risk score is less than 3, and if the score is more than 3, they comes under the high risk category. Another very easy scoring card is also available, and we can use to stratify our patient into the risk uh, risk categorization, like mild, moderate, and high risk. They have taken more total 14 points depending on the parameters of the subjective patient, like whether patient is having good ventricular function or not, PVR level, saturation level, crit level, arrhythmias, what type of treatment the patient is taken, and you can easily categorize your patient into the mild, moderate, and high risk. Why we need this risk stratification? To predict the intraoperative, perioperative complication, and to explain the risk to the surgeons as well as to the parents, so that they can decide whether to proceed for the elective surgeries or not. Now, the very important, that is section 2, preoperative evaluation. So as I told, we have to go in detail about the history of the patient. We should check the room air saturation, because that is the basal saturation of the patient, and we have our goal to maintain the same saturation in case of cyanotic heart diseases throughout the perioperative period. Blood pressure reading should be taken on all four limbs. So sometime incidental coarctation can be diagnosed if there is difference into the blood pressure. As I told, consent and proper risk should be explained to parents, because it's a pediatric patient. There is a high anxiety to the parents, and it is a very we have to fight against the emotional issues regarding these babies with the parents. Yes, labs are very important, as this consequences of cyanosis. There is increase in the creat, so we have to see the hemoglobin creat, the coagulation problems, so platelet, INR, APTT. WBCs sometimes may be higher if they have a subclinical infection because of the increased congestion or other problems. Electrolytes derangements can be there if they are on medications like diuretics. Glucose level should be checked and kept above the 100. Sometimes they have hypoglycemia because they have decreased synthetic function, the capacity is less. And in case of the hypoperfusion, they are not able to produce the glucose. VSD's patients, sometimes they are on digoxin, so we have to see the digoxin level if indicated. Liver and renal functions should be checked. Chest X-ray imaging, yes, we have to do chest X-ray for every patient. It will not be normal as others because of their structural changes. There are some differences in the chest X-ray. These are some terminologies for some typical conditions. For exam point of view, this is important. In ASD, VSD, PDA, and AV canal, we found the plethoric lung fields, and in Tetralogy of Fallot, we find oligamic lung field and boot-shaped heart. ECG also will not be normal as we get in adult ECGs. They have chamber dilatation, and so they have the changes reflected into the ECG. Echo also, the interpretation, the style is different. In pediatric, echo is detail about the structures of the heart. So the terminologies are also new, like situs, concordance, and regarding the pathology, presence of pulmonary artery hypertension and myocardial function is very important, whether your patient is having good myocardial function, contractility, or depressed myocardial function. Some patients, they have undergone MRI and CT for the detailed diagnosis of their condition, we have to go through all these investigations. As I told, moderate to large VSDs, they may have on some medications, or the cynotics, they also have on some medications. So we have to go in detail, and almost all medications can be continued in the perioperative period. Only we have to discontinue the digoxin and ACE inhibitors on the day of surgery. And antiplatelets, if the patients are having shunts like BT shunt or BDG, then we, and the surgery allows us to continue the antiplatelet, we can continue whenever possible. Infective endocarditis prophylaxis is very, very important for the patients with congenital heart disease undergoing for the non-cardiac surgery, mainly in the dental procedures, tonsillectomy, genitourinary and GI procedures. They need infective endocarditis prophylaxis. The indications are given here: unrepaired cyanotic congenital heart diseases, repaired with prosthetic material, repaired with any residual defect. These patients we have to give infective endocarditis prophylaxis. How to give? This chart gives us about the antibiotic we can give 1 hour prior to the procedure. Fasting and pre-medication guidelines, yes, as we follow for other pediatric procedures, same guidelines: 6 hours for milk, 4 hours for breast milk, and 2 hours for clear fluids. But just take care that the patient, specifically the cyanotic patient, should not be very much dehydrated. So if possible, IV line is there, you can start IV fluid in the preoperative area. Pre-medication is very, very important because the separation anxiety causes sympathetic stimulation, tachycardia, and so they may go with cyanotic spells in case of top. So calm, cool baby is always welcome into the theater. You can give pre-medication with pedicloryl in the ward itself, or you can give with injection ketamine, IM or IV, depending on the presence of IV line or not. Our protocol, we secure IV line prior day of the surgery, and we give ketamine, midazine, glyco immediately before taking in the OT. But the care, when we give these ketamine or sedatives, we have to see that patient is not hypoventilating because of these drugs. So just be careful when we are giving these drugs, IV or IM. Monitoring, when we take the patient inside the operation theater, non-invasive monitoring, ECG, NIBP, ETCO2 is must. Temperature should be normal. Pulse oximeter we have to put if the patient is having BT shunt, then avoid on the same side. If the surgery is indicated, the disease is severe, and we need continuous blood pressure monitoring, we can put arterial lines, CVP catheters, and Foley's to monitor the cardiac indices. Our protocols for these invasive lines, if the baby is less than 10 kg, we use the small caliber central lines and arterial lines. If baby is 10 to 25 kg, we use CVP of 5.5, arterial cannula 20 gauge, and we put femoral only, femoral arterial lines and IGV CVP line, or you can put the femoral vein. You can do the femoral vein also. Police is must to know the urine output, because these patients are very friable and they can go in fluid overload. So monitoring of good urine output is important. So whenever you are taking these patients, just keep in mind that these patients may have myocardial dysfunction, they may have arrhythmias, fatal arrhythmias, cyanosis, and their consequences we have to manage, and the severe pulmonary hypertension they have, and this crisis can occur in perioperative period. So, in the same context, we have to maintain the goals of our anesthesia management. We have to maintain the myocardial contractility, try to maintain the adequate pulmonary and coronary blood flow. We have to balance between the SVR and PVR. SVR is systemic vascular resistance, and pulmonary vascular resistance. In patients of cyanosis or the tetralogy of Fallot, we have to maintain high SVR so that the right to left shunting is reduced. And in VSD, large to moderate to large VSDs, we have to maintain normal SVR and maintain the PVR, or you can reduce PVR in cases of severe pulmonary artery hypertension condition a patient is associated with. So this is a cardiac grid, how to manage these patient. Only important thing in tetralogy of Fallot, never allow SVR to go down, because as SVR goes down, there is more flooding of the right sided blood to the left side and patient becomes more cyanotic. We have to maintain normal sinus rhythm in all conditions because cardiac output is depend on the heart rate. We can't do the myocardial depression because again hypotension leads to vicious cycle. For induction, when we start induction, if you don't have a IV line, you can start inhalation induction and you can secure IV line, but for that you need another anesthesiologist which is perfect in taking the IV lines immediately. Expert help is very much necessary, so it is always safe to take IV line prior in the recovery period. You can put local prelocaine over the veins, and without making baby cry, you can put the IV line and do the safe IV line injection. Our protocol is fentanyl, ketamine. Ketamine is the best drug because it has minimal effects on the pulmonary circulation and it has a SVR increases. So in case of cyanotic heart diseases, it helps to maintain the oxygenation or maintain the reduce the left to right shunt. Propofol and intermediate, if at all you want to use, you can use in small incremental dosage, but as far as there is no need if you use opioid, ketamine and midazolam induction. Avoid schooling because they, as I told you, they have many genetic problems associated with their disease. So we avoid schooling. If and muscle paralyzing agents, vecuronium and pancuronium rather than atrocurium, because atrocurium has histamine release hypotension. So better to go with vecuronium, pancuronium. Coming to the specific condition, as I told, ASD, we had to, in all conditions, we had to keep the normal sinus rhythm, good myocardial contractility. Now, coming to the pulmonary vascular resistance, in ASD patients, the pulmonary vascular resistance are not much high, but as there is increased flow to the pulmonary circulation, so we can keep normal or little elevated PVR. So PaCO2 we can accept up to the 40 to 50 millimeters of mercury. We don't have arterial PaCO2 monitoring every time, so you can put your ATCO2 figures up around the 30 millimeters of mercury. You can give PEEP up to the 4 to 5 centimeters of water, but if you give more PEEP and high ventilator pressure, PVR may increase at a level that shunt can be reversed. Avoid hypovolemia. Preload should be adequate. And the very, very important thing in all congenital heart disease, you have to give the infusions which are free of the air bubbles, because there is direct communication between two circulations. Air bubbles have devastating problem. So how to avoid air bubbles? You have to be careful when you are preparing infusions. You can give warm IV fluids rather than cold IV fluids. You can use dextrose or NS for preparing the infusion. So, and before while preparing, take care of the air bubbles. When you are injecting the IV drugs or fluids, you should remove the dead space in the three ways as well, very precautiously. So take care of air bubbles in all CHD patients. VSD, the aim is to we can decrease the left to right shunt by arterial vasodilatation, minimal decrease in the SVR, and we can again we can keep the PaCO2 at normal or little higher normal level, so reduce the pulmonary blood flow. We can induce these patients with isoflurane and sevoflurane. Neuraxial blockade, yes, spinal, we can give in VSD patients. Sometimes regional blocks for non-cardiac surgeries are acceptable for these patients as well. Again, the same, take care of air bubbles. So for moderate to large VSDs, we have to balance between the pulmonary vascular circulation. If they have documented systemic pulmonary arterial hypertension, we have to avoid more increase in the pulmonary artery hypertension. So the factors which increase this PVR, we should be aware that hypoxia, hypercarbia, and acidosis, increase intrathoracic pressure. These are the common factors which increase PVR. So we have to avoid them. Temperature management is also important. We have to keep the baby at normal temperature. So temperature monitoring is mandatory in all congenital heart disease patients. This is a list which decreases the PVR and which the factors which affect on PVR and SVR. Pulmonary artery hypertension crisis, as I told previously, the fourth condition with red flag. We don't want our patient go into the pulmonary arterial hypertension crisis, because if hypoxia, hypercarbia, or acidosis, there is sudden increase in the PVR. So right heart failure, again hypotension, myocardial depression, again decrease blood flow, and the vicious cycle go on and go on. So how to treat the pulmonary artery hypertension crisis? Perioperatively, we can give 100% oxygen. Oxygen is the potent pulmonary vasodilator. Hyperventilation so that PaCO2 comes down, analgesic to reduce the sympathetic stimulation, tachycardia. Whatever the acidosis has happened, we have to correct the acidosis with injection soda bicarbonate. We have to maintain the blood pressure. For that, we may need infusions of the inotropic drugs like adrenaline. Inhaled nitrous oxide, if available, we can give inhaled nitrous oxide, but it is not easily available everywhere. Oral or IV sildenafil we can give. If RT has put, we can give oral sildenafil. Bosentan and endothelin receptor antagonist are also available. We can give in the crisis management. Tetralogy of Fallot, we have to, as I told, check the baseline saturation and try to maintain the same baseline saturation throughout the perioperative period. Prolonged fasting should be avoided because dehydration can cause in the cyanotic spells. If the patient is creat more than 60, we can do the phlebotomy. We can remove the blood and we can rehydrate the patient with RL. Induction with IV agents is accelerated rather than inhalation agent because there is less pulmonary blood flow. The drug of choice for induction in Tetralogy of Fallot is injection ketamine, so small doses of fentanyl and midazolam. We have to maintain the heart rate and sinus rhythm. Yes, phenylephrine is a wonder drug to manage the Tetralogy of Fallot to keep the SVR and blood pressure maintained. Specific considerations during procedures for non-cardiac surgery. So these patients can come for the diagnostic procedure. We can do it under IV sedation safely. Laparoscopic procedures, if they are posted, then while giving the pneumoperitoneum, we have to be precautious and less pressure is acceptable, that is 8 to 12. If you are doing ortho procedures, when they release the tourniquet, just take care that there should be no much acidosis, and to prevent acidosis, you can give soda bicarbonate and keep the blood pressure. Head low and head up positions when you are giving for any procedure, just take care that they will not tolerate it very easily. And procedures with risk of air embolism, like many neuro procedures, you can communicate with surgeons and give the positions so that less air embolism chances can be there. Post operatively, good analgesia, opioids, and whenever regional is possible, you can give regional blocks. And vigilant monitoring in ICU is very, very important till the patient stabilizes. So last slide. Meticulous preoperative evaluation, multidisciplinary approach, involvement in teamwork, and the balancing skill between the systemic and pulmonary circulation is mandatory. And just keep them where they belong and maintain their pathophysiology. Thank you.